Thanks for joining me. My name is Dr. Kathryn Retzler, and I'm going to be talking about weight loss for longevity. You might already be familiar with the statistics. If you look at this graph, you'll notice that the solid line represents men, whereas the dotted line represents women. And the graph starts at about 1960 and goes through 2018. And you'll notice that something happens right around 1980 where the rates of obesity and severe obesity start climbing. So in less than 2 generations, we now have 73% of adults overweight or obese, and by 2030, 78% will be. Currently, 42% of all adults are obese and 50% of all Black adults are obese, whereas 9% are severely obese, which is defined by a BMI greater than 40. So I'm going to be talking to you about weight loss from 3 different perspectives. The first perspective is my own. So when I started medical school, I was 123 pounds, and when I finished my residency, I was 186 pounds. So that's 63 pounds on my frame, and I wasn't a very big boned person. So that was a lot of weight to gain in a short period of time, and I've learned a lot on my journey to lose that weight and maintain that weight loss. And I'll be talking to you about the research, since I keep up on the research and I lecture about overweight and obesity at conferences. And then also from my perspective of caring for patients for the past 24 years. So I've learned a lot from the thousands of people who I've served about what works and what doesn't to help with weight loss and maintenance of that lost weight. A little bit about my background. My undergraduate degree is in philosophy. I graduated from naturopathic medical school in 2001, and then I consulted at a hormone testing lab for 3 years before I started a private practice. My focus is on longevity medicine, and I have specialization in all forms of bioidentical hormone replacement therapy since I graduated. And I have special emphasis on brain optimization and preventive cardiology, having gone through a preventive cardiology fellowship and done quite a bit of continuing education on brain optimization. I lecture at age management conferences. I have for many years, and I love doing that. And I've published 2 books. My 3rd book, which I'm very excited about, is called Queen Bee: Tapping into Your Power, Desire, and Longevity, and it's expected to be published hopefully by the end of the year. So what are my goals for you? Well, I have 3 big goals for you. The first is to help you understand the relationship between overweight and obesity and longevity. So this is not about cosmetics, although that matters to a lot of people, including me, but it's really about how weight can shorten lifespan and health span, and how losing that weight can extend your lifespan and health span. So from the lens of longevity. I also want to help you identify the causes of obesity. So if you're overweight or obese, perhaps you don't really understand how that happened to you, and I'd like you to understand that by the end of this lecture. And then the 4 aspects to my program, Weight Loss for Longevity. And those aspects are accountability, mindful eating, hormone balance, and then supplements and medications that are available. A little bit about terminology. Obesity is a chronic disease that involves having an excessive amount of body fat. This is a diagnosis, not an identity. So hopefully we're taking the stigma out of having overweight or obesity, and we're now able to recognize that this is a chronic disease, not somebody's identity. So how do we define overweight and obesity? Well, first we can use a BMI, which is a body mass index. This is a calculation based on height and weight. And there are calculators available that can help you figure this out. There's a link to the CDC BMI calculator if you click on that. Essentially, a BMI of 25 to 29 is considered overweight, whereas a BMI of 30 or greater is obese. Now, this is different in Asian populations. So in Asian adults, 23 to 24.9 is overweight, whereas 25 or greater is considered obese. The limitation of a BMI is it doesn't take into account lean body mass, mainly muscle mass. So if somebody has a lot of lean body mass, they may be clinically obese, and yet they may be optimal when it comes to their body fat percentage. Other things we look at, the waist circumference. This is in inches. If it's greater than 35 in women or 40 in men, that is technically considered obesity, or visceral adiposity is too great. A waist to hip ratio. So this is measuring the waist, measuring the hips, and if it's equal to or greater than 0.85 for women, or greater than or equal to 1 in men, that's considered obese or abdominal obesity. Sometimes we look at a waist to height ratio. This isn't used that often, although we do calculate it and keep it on record for our patients. And then probably the most important is to look at fat and muscle percentage. And there's a couple of different technologies that we use in my clinic for that. One is a Seika machine, which measures bioimpedance, and the other is using a DEXA scan, which uses X-ray. So the limitation of bioimpedance is that it is very hydration dependent. So if you're dehydrated, the water doesn't carry the current, you won't have enough water, and so you may look fatter than you are, having more fat tissue than you do. DEXA is also somewhat hydration dependent, but less so. And the benefit of DEXA is that it can measure subcutaneous versus visceral fat, whereas BIA is less accurate at that. So why should you care about weight loss? Why does it even matter? Well, it matters because body mass index is a strong predictor of mortality. In fact, a BMI of 30 to 35, which is technically class 1 obesity, reduces your average lifespan by 2 to 4 years, whereas a BMI of 40 or greater reduces it by 8 to 10 years. That's the equivalent to smoking. The lowest mortality is seen in people with a healthy BMI of 20 to 25. And when it comes to fat mass and mortality, the information is even more valuable. The more fat you have, the greater the risk of dying from all causes. So that's called all-cause mortality, or ACM. And the risk of dying is even greater when you have more belly fat. So the more visceral adiposity or belly fat you have, the greater your risk of dying. In fact, if you're in the highest quartile, the highest 25% of visceral adiposity or visceral fat compared to the lowest, you have a 20% increased risk of all causes of dying, 22% from death from cancer, and 46% from cardiovascular disease. And visceral adipose tissue worsens with aging, unfortunately. So then you have more inflammation and more immune dysfunction. Also, there are at least 13 different cancers that are associated with overweight and obesity. So this comes from the CDC. So cancers of the thyroid, breast cancer in postmenopausal women, GI cancers like liver, gallbladder, stomach, and pancreatic cancers all increase with obesity. Colon and rectal cancer increases. Ovarian and uterine cancers, kidney cancer, multiple myeloma, which is a cancer of blood cells, adenocarcinoma of the esophagus, so esophageal cancer, and meningiomas. So all of those cancers increase with overweight and obesity, likely the insulin link, although there are other contributing factors. And here's the good news. If you're overweight or obese, losing weight decreases your risk of dying and being sick. So you'll have a lower likelihood of dying from diabetes, cardiovascular disease, and cancer, and less suffering, especially from arthritis pain, sleep apnea, and better mobility. Now, what's the 15 to 20% club? Well, unfortunately, only about 15 to 20% of people who lose weight maintain that weight loss. If we look at overweight and obese U.S. adults from a publication on long-term weight maintenance from 2010, 17% who lost at least 10% of their weight kept it off for a year. According to the National Weight Control Registry, which contains over 60,000 people, about 20% who lost 10% kept it off for a year. And then a meta-analysis that was published in 2001 of 29 different studies showed that more than half of lost weight is regained within 2 years, and within 5 years, 80% is regained. And unfortunately, there are no shortcuts. So I have had patients ask me, well, what about liposuction? So this was a study that was done, it was a small study on 12 women before and after liposuction. And the liposuction, which of course just targets the subcutaneous fat, not the deep visceral fat, which is so concerning, did not improve their insulin sensitivity in the muscle, liver, or fat tissue. It didn't improve blood sugar. It didn't improve their lipids, so their bad cholesterol. It didn't improve blood pressure, and it didn't lower any inflammatory biomarkers. So what are the causes of obesity? Well, there's 4 main categories. There's biological factors, genetic factors, environmental factors, and then of course behavior. And I want to talk a little bit about each of these. So what about biological factors? Well, one thing we know is that in utero epigenetic changes influence gene expression and can be lifelong. What does that mean? That means when your mom, whatever your mom was exposed to when she was pregnant with you, can affect you for life. In addition, if you're a woman who is thinking about getting pregnant or you're currently pregnant, what you're exposed to affects your offspring for life. And if a mother is undernourished or has nutrient deficiencies, this can increase obesity risk in the child. Methyl donor supplementation may reverse this. And then maternal obesity and gestational diabetes increases obesity risk. So if your mom had gestational diabetes or obese, this can increase the risk that you will. And the good news is that weight loss before pregnancy might prevent this. And lastly, what your mom was exposed to while she was pregnant with you in terms of any endocrine disruptors, chemicals in the environment that mimic estrogen mainly in a negative way, can increase the likelihood that you would be obese. What about genetic factors? Well, 25 to 50% of obesity risk is genetic. It might be up to 80% in severe obesity. There have been more than 500 genes identified, and most of these genes are related to appetite. Some influence fat tissue biology or energy expenditure, and I'll be talking more about genetic testing that's available later. But most cases are polygenic. There are very few single gene mutations that will cause obesity. Most cases involve multiple genes. But keep in mind that even if you inherited these genes, they don't act in isolation. So in other words, it's a combination of genetic risk with the environment. And speaking of environment, there are social determinants of health. These are non-medical factors that influence health outcomes. So this includes early childhood development, whether food was available while you were young. So food insecurity increases the risk in adults. Lack of access to healthy food or to physical activity, low education or unemployment and job insecurity. Environmental toxins, so again, endocrine disrupting chemicals have been linked with an increased risk for obesity, infections, and then importantly, the microbiota that inhabits the gut, otherwise known as the gut microbiome. And I'll be talking about this quite a bit later. We know, for example, that bacteria and viruses that are transplanted from obese mice into lean mice cause those lean mice to become obese. So there is definitely an influence about what's going on in the gut. And then, of course, behavior. So diet plays a role, activity plays a role, whether or not a person is sedentary. There's something called non-exercise activity thermogenesis. This is abbreviated NEAT. This is the calories that you burn just by fidgeting or standing, doing chores. It can differ quite a bit between people, up to 500 calories. Whether or not you exercise, which has been shown to help maintain weight loss more than it helps with weight loss. Psychological factors and cultural factors. And then one area that doesn't get enough attention is circadian rhythm misalignment and sleep disruption. So if you eat food at night when you should be sleeping, you're more likely to gain weight and have worse glucose control. But the bottom line is that if you absorb more calories than you burn, you can gain fat. And notice I say calories absorbed. And that's because there are a couple of areas where the calories that you take in may not equal the calories that you absorb. For example, if you eat a high fiber meal, that's going to slow absorption of food into your GI tract. So fiber can play a role in calorie absorption, as well as a high protein diet, since metabolizing the protein can cost more calories than metabolizing other macronutrients. But for the most part, when you absorb more calories than energy burn, you can gain fat. And this is in part because of the set point. So we need to talk about the set point theory. And this is very important, that the human body will adjust to and defend an increase in body weight. When I think of the set point theory, I think of Veruca from Willy Wonka, because she was so stubborn. And the set point theory is essentially a range, give or take, of about 5 pounds. And it's essentially saying that obesity protects obesity. What does that mean? That means after weight loss, the body tries to return to the higher body weight. And it does this by two main mechanisms: increasing appetite and then decreasing the calories that you burn at rest. So decreasing the resting metabolic rate. This is known as adaptive thermogenesis. And if you lose 10% or more of your body weight, you have a 300 to 400 calorie reduced energy expenditure below predicted for your new weight. And these two mechanisms really are contributing to your weight going back up. So this slide may seem complicated, and it's not important that you memorize all of this, just that you understand the concept. And the reason that it's so easy to regain lost weight is mainly because of 3 different body systems: the brain, specifically an area in the hypothalamus, the fat tissue itself, and then the GI tract. So starting with the fat tissue, when you lose fat, you don't lose your fat cells. You lose the fat within the fat cells. And the main hormone that is responsible for your appetite that can come back is leptin. So we'll be talking about leptin. Leptin is secreted from the fat cells. And then if we look at the GI tract, there are several participants. One is the stomach through the making of the hormone called ghrelin, and the pancreas making hormones insulin, amylin, and glucagon. We'll be talking a little bit about insulin in particular. The small intestine, which makes GLP-1, GIP, CCK, and peptide YY. And I'll be talking a little bit about those hormones and neuropeptides. And then the brain. So what's happening in the brain? Well, there are neuropeptides that decrease appetite and increase energy expenditure. And that includes alpha melanocyte stimulating hormone, pro-opiomelanocortin, or POMC, and cocaine and amphetamine regulated transcript, or CART. The neuropeptides that increase appetite and decrease energy expenditure include neuropeptide Y and agouti-related peptide. So again, not important that you memorize those, just that you're somewhat familiar with the fact that this is a relationship between the hypothalamus, an area in the brain, the fat cells themselves, and the GI tract. And I think of it like having your foot on the brake and the accelerator at the same time. But when hunger increases, when you push down on that accelerator, you're also pulling your foot off the brake. So what happens with hunger? Well, hunger causes a decrease in energy expenditure. It mainly involves neuropeptide Y and agouti-related protein in the hypothalamus that we talked about. It's stimulated by ghrelin, that's the main hunger hormone, and it's inhibited by the hormones that stimulate the brake. So GLP-1, GIP, PYY and PP, leptin and insulin, very important. We'll talk about that, and amylin, which is playing more of a role, or there's more research coming out on that. And then when it comes to the satiety or the brakes, this increases energy expenditure and then decreases appetite. Again, alpha melanocyte stimulating hormone, POMC, CART, and this is stimulated by GLP-1 and GIP. So there's a lot of interest in these drugs. We're going to talk about the drugs themselves, but we'll talk about other things that increase these neuropeptides and bind to these receptors. So leptin and ghrelin are kind of like a seesaw. Ghrelin is your hunger hormone. It comes from the stomach and it peaks before meals. This is what makes your stomach growl. And normally, ghrelin decreases in proportion to calorie intake. So as you start eating, ghrelin starts to go down. Interestingly, if you drink beverages that are sweetened with fructose, like pop, it prevents you from feeling full. It doesn't dampen the reduction in ghrelin. Ghrelin suppression with meals may not occur as well in people with obesity, and poor sleep increases ghrelin. This is why you may notice if you get up really early for a flight or you don't sleep well that your stomach tends to growl more. What does ghrelin do? Well, it stimulates glucagon release from the pancreas and glucose production from the liver. It's trying to raise blood sugar. It also, interestingly, stimulates growth hormone release from the pituitary. So maybe there's a purpose to actually feeling hunger. And remember, it stimulates neuropeptide Y from the hypothalamus. So what about leptin? Leptin does the opposite. Leptin is made in proportion to the amount of fat you have in your fat cells. Leptin deficiency, though, is very rare. This leads to severe overeating and obesity in childhood. Most cases of obesity are associated with high leptin, and this is because leptin resistance develops. The primary role of leptin is really to defend against fat loss. So when you lose fat in the fat cells and your leptin level drops, it triggers hunger and it decreases energy expenditure. If you've ever fasted for multiple days, sometimes you'll notice a rapid drop in leptin, and this can lead to severe hunger. So now let's talk about the incretins. And again, you don't need to memorize this. This is just to help you become familiar with these terms. So incretins are hormones that are made by the gut, mainly glucagon-like peptide 1, which is abbreviated GLP-1, and glucose-dependent insulinotropic polypeptide, or it's also called gastric inhibitory peptide. This is GIP. And these stimulate insulin release and they inhibit glucagon release when calories are eaten, when carbohydrates are eaten, with the goal of lowering blood glucose. They're rapidly degraded by DPP-4 enzymes, or dipeptidyl peptidase 4 enzymes. And so this will give you information about the first drugs that were developed. They were inhibitors of this enzyme, which would keep GLP-1 and GIP around longer. But GLP-1 does a couple of interesting things. First, if you think about what's going on in the brain, which is where most of this drug is active, it decreases hunger. And this is because it inhibits neuropeptide Y, an agouti-related protein, and stimulates that POMC-CART. So it decreases hunger and increases satiety, being satisfied while you're eating. Interestingly, it also changes food cravings and preferences. So this is the main mechanism for how the GLP-1 agonist drugs are acting. So what happens with weight loss when it comes to satiety and hunger hormones? This is a study that was done in 50 people who had overweight or obesity. And the study was to put them on a very low calorie diet. It was essentially a meal replacement along with some vegetables. 500 to 550 calories a day for 10 weeks. And then at the 10-week mark, they were given advice on how to maintain their weight, and it was recommended that they continue exercising for 30 minutes a day. So the researchers measured baseline 10 weeks when when the low-calorie diet was stopped, and then a year later, their appetite, measured the hormones and peptides involved in hunger, so ghrelin and GIP, and in satiety, leptin, peptide, YY, CCK, pancreatic polypeptide, and amylin. And what did they find? Well, at 10 weeks, their satiety hormones decreased, and their hunger hormones increased, and their appetite increased. And unfortunately, at 1 year, the same was true. So their satiety hormones remained low and their hunger hormones remained higher. And then this is a study that was done on The Biggest Losers that was published in 2016. And that was a game show where participants competed to see who could lose the most weight. So at the end of the 30 weeks, the weight loss was on average 128 pounds, tremendous amount of weight loss for 30 weeks. Their resting metabolic rate, the number of calories they burned at the end of the show, had dropped by an average of 610. After 6 years, they regained most of their weight. Most of the participants regained most, if not all, of their weight. Some of them gained more than they originally lost, and their resting metabolic rate had dropped even a little bit lower. And this was after 6 years. So after 6 years, they still had a slower metabolism. It's estimated that for every 2.2 pounds of weight lost, that's a kilogram, that appetite increases 100 calories and calorie expenditure decreases 20 to 30 calories. So if you really think about that, it's kind of a setup. If your appetite goes up by 100 calories and your calorie expenditure goes down by 20 to 30 calories for every 2.2 pounds of weight lost, it's nearly impossible to maintain weight loss. Again, this is because hunger hormones increase, mainly ghrelin, satiety hormones decrease, so you're less full, and metabolism slows. It's like a tug of war. And it's a very difficult thing to overcome on your own. And this is why I talk about obesity as a chronic disease. In fact, in 2012, the American Association of Clinical Endocrinologists recommended that obesity be classified a chronic disease and perhaps even renamed ABCD, or adiposity-based chronic disease. But I would like to offer you some help. And before we talk about options, I'm going to ask that you pause and that you release any assumptions and judgments you have, either toward people who struggle with weight or toward yourself if you struggle with weight. So oftentimes patients will come in and they've internalized a lot of the judgment and assumptions that we have collectively as a society and unfortunately as a medical establishment. And that is that weight loss is really just about trying harder, you need to move more, you need to eat less, and that it's your fault if you don't. So I'm going to ask that, at least for the rest of this lecture, you consider the science that I'm going to present to you, and you release any assumptions and judgments you have up until now about that. So in my weight loss program, the first thing we do is clarify goals and consider the patient's history. And when it comes to your goals, I recommend that you're specific. It takes at least a 5% weight loss to decrease weight-related health problems like diabetes and fatty liver. So ideally, 5% weight loss would be a goal from a health perspective, but perhaps your goal is to lose more weight than that. We talk to patients about when they started losing weight, and then any sudden jumps like medications that may have played a role, or illnesses, major life stressors, whether women gained weight at pregnancy or during menopause, and then their lifetime maximum. What's the highest body weight that you ever achieved, which of course your brain would always like to go back to. So remember, that could be the hypothalamus's set point. And then what's worked in the past and what hasn't worked. What are your successes and failures? Because obviously we don't want to repeat the failures. And then we do measurements. So we measure weight and height to calculate BMI. We look at fat and lean body mass. This is done via the SECA that I mentioned and via a DEXA, because we do want to document visceral versus subcutaneous fat. We do a waist circumference and then a waist to hip ratio, which, by the way, is the best, has the best association with mortality. So I would recommend that you start by doing some or all of those measurements. And then we introduce the 4 stages of the program, and that is accountability, mindful eating, hormone balance, and supplements and medications. So the rest of this presentation will be talking about those 4 different areas. Starting with accountability, very important to have some degree of accountability, whether you weigh yourself daily, which I recommend everybody does, whether you report in with a weekly weigh-in or a check-in or journaling, keeping a diet diary. Some people like a point system, like Weight Watchers. Some people like apps that count calories or keep a visual diary, and then some sort of a movement or exercise diary. If your stress level is high, maybe measuring that, looking at heart rate variability or any way that you can get feedback about your stress or your sleep, if that's playing a role. So some form of accountability. And in my program, we have a functional medicine coach that we use in addition to being accountable to me for my personal patients to help maintain weight loss and also help with the accountability piece. And when it comes to daily weighing, some people really don't like to weigh themselves daily, but I really recommend you get into the habit. People who weigh themselves daily are more able to prevent weight regain. And there is research showing that frequent self-weighing doesn't really contribute to a negative mood or body image as long as you recognize that it's a number, and the number is just information. So if you get on the scale and you start to have thoughts or negative opinions about yourself, this is an opportunity to remind yourself that the scale is a number and you're just using that as a tracking method, just like all forms of tracking. So what are calories? Well, the heat burned from burning food in a fire is the same as the heat burned in the human body. The oxygen consumed and the carbon dioxide produced is the same. Technically speaking, a calorie is the energy to raise 1 milliliter or 1 kilogram of water by 1 degree Celsius. And food is actually in kilocalories, but we just use the word calorie because it's a little bit easier. I have a lot of respect for fat tissue. I mean, when you think about it, adipose tissue is extremely energy dense. It is a way of storing an extreme amount of energy. It's about 3,500 calories per pound. This is 80 times the energy of an alkaline battery. It's 5 times the energy of nitroglycerin. And frankly, it's similar to jet fuel, and I looked all those up just to make sure I was accurate. So it's pretty amazing that we as human beings can store that kind of energy. So what is your basal metabolic rate? This is how many calories you need every day at rest. The brain takes about 20% of the calorie needs, the liver and heart about 12%, your kidneys 9%, and the lungs 5%. And there is some contribution from the gut, but this is harder to quantify because of the microbiota. It's essentially 60 to 75% of your total energy expenditure. And it's influenced, of course, by genetics, your age, body composition, and I should put on there hormones play a role in a basal metabolic rate. So first, let's have a food fight. Let's talk about diet. Which diet is most effective for weight loss? Well, there is a lot of research. There's some research showing that low carb and high protein diets are better than high carb, low fat diets for up to 6 months, but not if the study was 12 months. There's some research showing that low carb Mediterranean diets are better than low fat diets. There's even research that a vegan or plant-based diet is better than a non-vegan diet for weight loss. And then there's research that a very low calorie diet, so a true ketogenic diet, is better than a high carb diet, but maybe not if calories are strictly controlled. So what about macronutrients? Well, this is a study looking at 800 overweight adults that were assigned to 4 different diets based on the amount of fat, protein, and carbohydrates. So there was the low fat diet, which was 20% fat versus the high fat, which was 40%. There was the low carb diet, which was 35% versus the high carb, which was 65%. And then participants ate either 15 or 25%. They called 25% a high protein diet. The participants received group and individual counseling. And what did they find at 6 months? Well, the average weight loss was about 7% in all the groups. They all started gaining weight by a year. At 2 years, the average weight was similar between groups. Satiety, hunger, and diet satisfaction were similar between the groups. And what was most associated with the best weight loss was actually attending group sessions. What about ultra-processed food? Well, if you want to make a rodent fat, give them the cafeteria diet, essentially the food that you'd find in a cafeteria, because this changes their eating behavior, it lowers the value of other rewards, and it reduces perceived stress. Same thing happens in humans. What is ultra-processed food? These are industrial products, mostly or entirely made from substances derived from food with little or no whole food. They contain ingredients not used in cooking, for example, artificial colors, preservatives, emulsifiers, that's why I make my own ice cream now, added or altered fats, salts, and sugar. And they include things like soft drinks, chips, chocolate, candy, ice cream, breakfast cereals, mass-produced breads, packaged soups, hot dogs, fries, chicken nuggets. You know if ultra-processed foods because they come in packages and they don't come from the earth. This makes up about 60% of the American diet. It increases cancer risk, and it's usually found in plastic, which increases the accumulation of microplastics in your body. So does ultra-processed food cause weight gain? Short answer is yes. This was Kevin Hall's study where 20 subjects were put in a hospital setting, and they were either fed an ultra-processed or an unprocessed diet. Now, interestingly, these diets were presented in random order, but they were matched for the amount of calories, sugar, fat, fiber, and macronutrients. And each participant was put on the ultra-processed or the unprocessed diet for 2 weeks, and then they were switched. And when the participants were on the ultra-processed diet, they ate about 500 calories more and gained weight. So simply processing food alters weight gain. So what about meal timing, the timing that you eat your food during? Well, people have heard of time-restricted eating. This is sometimes called intermittent fasting. I tend to call it time-restricted eating because it's not really fasting. It's compressing your eating window into a certain time. And there is research showing this might improve weight loss, fat mass loss, and insulin resistance, but not if calories are controlled. So if you're eating the same amount of calories, it probably won't help. Now, there is research showing that people who are night eaters or eat most of their calories at night can have an increase in weight. This is an interesting recent study that was presented just recently in 2025. It hasn't been peer reviewed yet, but it was called the chrono diet, where participants were randomized whether or not they were morning or night owls. They were given the morningness, eveningness questionnaire to determine that, and that's a questionnaire you can take yourself. I mean, most people know if they're a morning person or a night owl or somewhere in between. And the people who were morning people ate most of their calories, 80%, at breakfast and lunch, whereas the people who identified as being night owls ate most of their calories at lunch and dinner. And what they found was that people who really were night owls tended to have better weight loss if they ate according to their chronotype. So it might be useful to eat most of your calories based on when it makes sense for your body to be doing that. So what can we agree upon when it comes to diet, timing of eating? We can agree that all diets can work short term. Weight loss is mostly about calories. We can agree that fiber is good and protein is good, and ultra-processed food is bad. Hopefully we can all agree on that. Also, counseling and lifestyle intervention matters. So, getting some help and some support and some accountability matters. The regain of lost weight is the norm. It's not a character flaw, it is the norm. So you need a long-term strategy instead of a diet. Part of that strategy needs to be developing mindful eating. So how many decisions about food does the average person make in a day? What would be your guess? And this is some research that Brian Wansing did at the Food and Brand Lab back in 2007, that the average person makes 200 decisions every single day about food. That is a lot to think about if you're not eating mindfully. What about regions? So this was another study that Brian Wansing published, giving about 130 people in Paris the same question as people in Chicago. They were asked, how do you know when it's time to stop eating? And the results showed that Chicagoans tended to say things like when they ran out of a beverage, or when their plate was empty, or when the TV show was over, whereas people in Paris said when they no longer felt hungry. Normal weight people are more likely to be influenced by internal cues to stop eating than by external cues. And overweight people are more influenced by external cues. So part of the goal of mindful eating is to help you develop those internal cues. But unfortunately, most people are unaware of how their environment influences their eating or drinking decisions. And Brian Wansing does some great work showing that the package size, a serving bowl from a bowl or a plate instead of eating out of the package, the location you eat in, your eating companions, whether or not you're eating with people who have healthy eating habits or people who have overweight or obesity. Even the body weight of the server at the restaurant influences decisions. So people are more likely to order dessert, for example, from a server who has overweight or obesity because of the permissive effect. So I want to introduce the way that I talk about hunger or becoming more of a mindful eater to my patients to you by talking about the types of hunger. And I think of it as physical hunger, mouth hunger, or psychological or emotional hunger. So let's start with physical hunger. Physical hunger involves the brain and the peripheral nervous system, the endocrine system, so your hormones, fat cells, and the GI tract. And we talked quite a bit about ghrelin. This is made from the stomach and the duodenum. Remember, this is causing your stomach to growl. And then leptin, which is secreted by the fat cells, that inhibits hunger in a normal person. Normally, it should inhibit hunger. What about mouth hunger? Well, in Japan, they use the term kuchisabichi, which means feeding a lonely mouth. So if you're eating because there's food around or there's environmental cues, like it's time to eat, maybe you're not physically hungry, but it's time to eat, seeing or smelling food. So if there's food available, if you see it and you put it in your mouth, even if you're not hungry, you're engaging in that mouth hunger or kuchisabichi. Boredom. Also, if the timing between meals is too great, this can lead to physical hunger and mouth hunger. Or sleep deprivation. You tend to eat more when you're deprived of sleep. And there are many psychological or emotional reasons for eating, like unmet needs. Oftentimes I see this in women, but of course it's true for men too, that if your own needs aren't being met, sometimes you'll eat as a reward. Not setting healthy boundaries or stress, all of that will trigger psychological eating. And the question is, do you eat to live or live to eat? And it's very important to differentiate this and whether or not you may have a true addiction. So I just want to talk about that very briefly. A definition of an addiction is a compulsive, chronic, physiological or psychological need for a substance or behavior despite its harmful effects. And usually there'll be symptoms if that behavior or substance is withdrawn. So anxiety or irritability. And this is a questionnaire that was developed by Yale. It's the food addiction scale, and there's a link to it at the bottom of the slide that you can click on to take this quiz to see if you may have a true food addiction and perhaps need some professional help with that. So I'm going to be talking a little bit about mindful eating and ways to develop mindful eating, but just to let you know, there is research on this. This was a small study in 10 people over 3 months that met for 2-hour group sessions weekly for 6 weeks, and then they did follow-up sessions every couple of months. And the emphasis was on teaching body sensation awareness, becoming aware of emotions, and then the triggers to overeat. And the participants lost weight. They decreased the likelihood of binge eating episodes. They had less depression and perceived stress. And even their inflammatory biomarker, their CRP, went down. And mindfulness training has been shown to help with weight loss. It improves eating awareness, stress management, and your ability to regulate emotions. So here are some tools that we use in my Weight Loss for Longevity program to teach mindful eating. I hope some of them are really valuable for you. We'll start with the first one, which is a very important one for people who have a spiritual or religious mindset. And that is that your body is a sacred place. So if you treat your body like a sacred place, ask yourself if you would dump garbage into a temple, mosque, or church. If your body is a sacred place and you're putting in garbage, you may be doing the same thing. Also, pause before and while eating. Giving thanks and becoming present with your feelings or centering yourself can prevent overeating. So there's perhaps a purpose to saying grace or just being present before eating. The faster we eat, the more we eat. It takes about 20 minutes for that satiety signal to register. And healthy weight people actually spend more time eating than those who are overweight or obese. So slowing down, pausing, giving thanks perhaps before and during the meal, very important strategy. This is another one that you can start doing immediately, and that is before you go to eat something, ask yourself why you're eating it. You can even do this afterward just to become more aware, more mindful. And the goal is not to be judgmental. I can't believe I ate that. It's really to maintain an attitude of curiosity. I wonder why I'm about to eat, or I wonder why I ate that. Was I physically hungry? My stomach was growling. Was I engaging in kuchi-sabichi, feeding a lonely mouth? There was food around, so I just put it in my mouth. Or did I eat because I had a feeling that I wanted to go away, or because my needs weren't being met, and so at the end of the day, I just want to eat and feed myself for emotional reasons. So really getting clear about why you're eating. Emotions don't have to control your behavior if you start to examine your thoughts. And there's a couple of very simple tools that I teach patients and I use myself. One is acceptance and commitment therapy, or ACT. And this is a set of skills that you can learn that will help you defuse unhelpful thoughts. So the goal is not necessarily to try to change your thoughts. That's very difficult, sometimes impossible to do. The goal is to help you learn, if a thought is not helpful, how to become more mindful of that thought, how to not be connected or fused with that thought. And I love Russ Harris's books and programs. I recommend them to all my patients. I've read them and taken his program myself. His book is called The Happiness Trap, and he has an online program where you can learn this set of skills, and repetition really helps. So this can become a habit itself, is to practice acceptance and commitment therapy. And another thing, which, it's part of acceptance and commitment therapy, is to pause before you eat something, feel what you're feeling, and simply name it. Now, this sounds really easy, but it does take practice. I'll give you an example of when I did this in my own life. So I was sitting in my massage chair one night and I got a thought, I'm going to go bake some cookies. So I went to the cupboard and I started pulling things out of the cupboard. And then I thought, I'm not really hungry. Maybe this is about something, but I wasn't really sure what it was. And oftentimes we're not. we don't know what we're feeling and why we're about to eat something unhealthy. So I went into the computer room where my husband was, and I prepped him. I said, I'm about to make cookies, and I know this must be about something, but I don't really know what I'm feeling. So I need you to listen to me. I don't want you to fix me. I don't want you to comment. Can you just listen to me? Something must be coming up for me. And out it came. I wasn't even really aware of my feelings until I had somebody there as a witness. So whether you have someone in your life that you can talk to about your feelings that may be causing you to make unhealthy food choices, or you use a diary, we have, a functional medicine coach, and she uses this technique. But this is very important to learn what you're feeling and simply put a name to it. That itself can help you defuse. Another important tool is to only eat when you eat. In other words, don't eat while driving or doing other things. Distracted eating is actually dangerous. Driving and texting while eating causes 3,000 fatal car accidents a year. And eating in front of the TV or the computer or the phone increases calorie consumption. It's more likely to lead to overeating because you're distracted. And actually, it leads to snacking and more eating later that day. So we don't eat in front of TV. I've gotten better at not eating at my desk in front of a computer, to just be present when you're eating. So when you eat, just eat. Another important tool is to control your food environment. We know that prompts, cues, and stimuli in the environment influence eating behavior, which is why it's super important not to keep food in view. So don't keep food on the countertops where you see it. Perhaps you walk past a row of cookies 10 times, but you eat it the 11th time. You get no credit for the 10 times. So keep it out of your view. And serve food from the kitchen rather than keeping it on the table. This is something that I engage in. My husband and I sit down to dinner every night. I portion the food in the kitchen and bring it to the table. We do this when we have guests. We don't have food on the table where it's so easy for people and ourselves to take seconds. Also, watch your language. Words transmit powerful messages to the mind, and the mind translates those to the body. In fact, when you repeat words to yourself, you are programming your mind. And see if you can identify any of these things that you may be saying to yourself, a type of self-hypnosis. For example, I just look at food and gain weight. A moment on the lips, a lifetime on the hips. I'm starving. Uh-oh, better hold on to weight then. Doesn't matter what I eat, I can't lose weight. Boy, have I heard that a lot in my practice. My mother's favorite, I live for chocolate. Okay, another strategy is to focus on what you need to eat instead of what you shouldn't be eating. So take the focus off of what you need to avoid or what you think you should be avoiding, and focus on whether or not you're getting your daily food needs met. First, protein. 30% protein diet, a high protein diet, is one of the few ways that you may help lower your set point. The other is through exercise. You need 1.2 to 1.6 grams per kilogram of body weight of protein a day. So divide your weight in pounds by 2.2 and multiply by 1.2 to 1.6, and you'll know what your protein goal should be in a day, closer to 1.6 grams. Adequate fiber. So make sure that you're focusing on getting enough fiber, ideally at least 30 grams a day, because it fills you up. It also feeds that gut bacteria that ferment the fiber into short-chain fatty acids, which increases satiety. We'll be talking about that later in the supplement section, but more important to get fiber from your diet. Fiber, of course, is also found in vegetables and fruit, as well as all the wonderful antioxidants, so making sure you're getting enough produce in a day, ideally from a variety of different plants. So thank you, Deanna Minich, for the idea of Smarty plants. The goal is maybe 30 different Smarty plants in a week. This can be from different produce or legumes, nuts and seeds, whole grains, herbs and spices. And then healthy fat, making sure that you're getting fat from healthy sources. So focusing on what you know that your nutrition needs are in a day instead of what you should be avoiding. And also adding fermented and cultured food, again, to help optimize that gut microbiota. Really important to keep your blood sugar stable so you don't end up on a blood sugar roller coaster. So avoid or limit refined and simple carbohydrates and ultra-processed food. Especially don't start your day with that, otherwise you will be on the roller coaster. Making sure that you're getting plenty of fiber, fat, and protein, again, to help keep your blood sugar stable. And, practice not clearing your plate. So eat the best and leave the rest. One thing that I do when I go to a restaurant, because portions are nearly always too big, is to ask for a container before my meal is served or with my meal so I can wrap it up before I eat it. And when you're satiated and you've had enough, but there's still food on your plate, if you're not going to take it home, one thing I've been known to do is actually turn the pepper shaker upside down and pour it all over the food so that I won't touch it again, because it's too easy to just keep practicing kuchi sabichi because that food is sitting there, so you just keep putting it in your mouth. Important, of course, to control portion sizes. So never ever eat out of a bag or a container. You cannot determine how much you're eating, and you will nearly always overeat if you're not actually looking at how much you're serving yourself. So always eat off a plate or out of a bowl. Use smaller plates. We already talked about avoiding eating in front of the TV or computer because it's very hard to control your portions. And then, of course, if you're still hungry, taking seconds of vegetables and protein. Here's some quick and easy serving sizes. If you're paying attention to that, a cup is about a baseball. A half a cup is about the size of a computer mouse. 3 ounces is a deck of cards. The palm of your hand, most people, is about 4 ounces. And eat like the Japanese. So a Japanese meal is about 50% smaller than the American meals, mainly consisting of fish, soy, vegetables, rice, and green tea. Wonderful saying, and forgive me if I pronounce this wrong in Japan, harahachi bunmi. So stop eating when you're 80% full. Of course, it does take time for you to feel full. And then eat like a crane. Perhaps that's why they eat with chopsticks. Definitely decreases the amount that you'll eat. And be a conscious shopper. Your brain enters a supermarket trance when you go into the grocery store. Beware of overbuying. Really important. So I recently spent some time with some very dear friends who, there's only 2 of them, but they go to Costco, and I noticed the amount of food. So if there is so much food available, there's going to be more of a desire to eat it. We all don't want to waste food. And you may end up buying way more than you need. So be a very conscious shopper. If you don't have a huge family, going to Costco to buy something in a huge size really isn't doing you any good. I mean, consider maybe going to the market more frequently. I go almost every day, or my husband goes for us based on what we need, so that we don't have a ton of food stored in our house where it's much easier to overeat. And prioritize your sleep and a normal circadian rhythm. Inadequate sleep, as we talked about, increases ghrelin and decreases leptin. And restricted sleep has been shown to lead to an increase in 250 calories a day. If you sleep less than 6.5 hours a night, increasing your sleep has been shown to decrease calorie intake and help with weight loss. And then if you're a shift worker, if you are awake in the middle of the night and sleep during the day, Unfortunately, eating when you should be sleeping decreases energy expenditure and increases appetite hormones. It also promotes unhealthy choices. So very important to be aware of that, and if there's anything you can do about it to make sure you align your circadian rhythm to the time that you should be sleeping and you should be eating. Exercise, this of course goes without saying. Very important to increase fat burning hormones and to improve insulin sensitivity in the muscle tissue especially. Moderate to vigorous exercise improves healthy food preferences, and it even helps with sugar cravings acutely. So you've got a sugar craving, try doing 2 minutes of an exercise snack, push-ups, marching in place, something, and then rate your craving afterwards and see if it helps. Thank you to Dr. Rhonda Patrick for this idea of exercise snacks. So this is essentially exercising for 1 to 2 minutes several times a day. You could set your alarm, you could set your computer so that you remember to do this. But exercise snacks have been shown to improve cardiometabolic health and lower blood sugar. So they matter, not just to give yourself a break, but maybe to help with food cravings and also to help with your blood sugar and your metabolism. And then trying to shift the reward value of food. So finding other things that feel rewarding, spending time with friends, getting a massage, prioritizing stress management. So if you're stressed, really recognizing that stress management, ways to empty your stress bucket, needs to be a priority if you are actively trying to reach a lower body weight. And I want to talk a little bit about the heart-brain connection, thanks to going through training with HeartMath Institute. And what the HeartMath Institute discovered is that the heart actually sends more signals to the brain than vice versa. So I'll repeat that because it was so startling to me to learn that. I tended to think that your thoughts impacted your heart, but really the heart actually sends more signals to the brain than the brain does to the heart. Stress and negative emotions cause erratic and disordered heart rhythms, which can cause problems with thinking. This inhibits clear thinking and reasoning. It actually inhibits impulse control, so you're more likely to act than think through a thought, and leads to emotional dysregulation. And improving heart rate variability leads to improved coherence. So if you are willing to go through training to improve your heart rate variability or do things that improve heart rate variability, this might help you with weight loss because it may help with impulse control, with emotional regulation, and it will decrease cortisol. So we'll be talking about cortisol in a little bit when I talk about hormones. And the HeartMath Institute has a device called the Inner Balance Coherence Plus. I have nothing to do with HeartMath. I don't have any affiliation with them. I just think they're a great organization in terms of the research that they've put together, which you can check out on their website, and the fact that they're trying to teach people, including children, to improve their heart rate variability, to reduce stress and anxiety, and to improve coherence. So if you click on that link, you'll be taken to the Inner Balance Coherence Plus website where you can order this tool, and it goes on your ear to take your pulse to be able to generate your heart rate variability. And the app will take you through different exercises where you can learn techniques that improve heart rate variability. If you use the code VHEALTH, VHEALT, they give people a 10% discount. Again, I don't have any affiliation with them, but I think this is a great tool. I've used it myself. I've purchased it for all my staff members, and I recommend it to patients. Another tool you can use to help break those unhealthy food relationships is to reprogram your mind. I call this installing new software. And this is partly why we have a functional medicine coach to help our patients in their weight loss program. There are many different visualization or hypnosis apps, and then even emulating somebody you admire. So faking it till you make it. And I've had patients tell me that, say, you know, I thought of you and what you might do, and then I did that. Great, that fake it till you make it. And eventually through neuroplasticity, that will become your thoughts. Another tool is to really recognize that food is a form of art. This is a fun study. If you look at the painting on the left, the Kandinsky painting, this research was trying to determine whether or not food presented artistically made a difference. So the participants were 30 men and 30 women. The same ingredients were used to try to present food either as artistic, like the Kandinsky painting, in what they called a regular presentation, or in a neat presentation. So same exact ingredients, but the participants said the artistic presentation simply tasted better. So I thought this would be a good time, since I've been talking for a long time and you probably need a little bit of a breather, to just show you some great food art. This is a good one, especially if you have kids. Very clever, that one. And probably my favorite, the watermelon, the thirsty watermelon. So what about other tools that might be helpful? I love this book, an app by Dr. Judson Brewer, who's a psychiatrist who studies how people change their habits, specifically around addictions. And he wrote a book called The Hunger Habit, which is about recognizing your unhealthy habits and changing them. And the loop that he talks about is the trigger behavior reward. So identifying the trigger, and then the behavior, and then the reward you got from that. And if you want to change eating behaviors, you need to change the reward value and find new rewarding behaviors. And he created an app that will help you do this called Eat Right Now program that was shown to reduce craving-related eating by 40%, which is very impressive. So this is a great app that you can download and use to decrease your food cravings and unhealthy eating behavior just by learning new ways to deal with your habits. So let's shift gears and talk briefly about obesity phenotype testing. This is really allowing for precision medicine when it comes to the treatment of obesity. And this is by a company called Phenomic Sciences. Again, I have no affiliation with them. I have used this testing in my practice, and I think the research they did was really interesting to come up with 4 different obesity phenotypes. And those phenotypes are hungry brain, hungry gut, emotional hunger, or slow burn. So somebody with a hungry brain obesity phenotypes struggles with satiation. So feeling like they're satiated while they're eating. Somebody with a hungry gut may have problems with satiety, so feeling hunger in between meals. Somebody with emotional hunger may have problems because they're eating for the reward that it brings them emotionally. And then somebody with a slow burn obesity phenotype may have a slow metabolism. And how did they determine these obesity phenotypes? Well, there were 450 participants. Most of them were females, the average age of 39, and their average BMI was in the obesity range of 37. They measured their body composition, resting energy expenditure, questionnaires related to satiety and satiation, their eating behavior, and their physical activity. And of the participants, they were able to determine an obesity phenotype in about 85%. The pure hungry brain was about 16%. Again, this is abnormal satiation. So these people would consume more calories without feeling full. So while they're eating, they don't have a normal satiation. The hungry gut phenotype was about 18%. This is abnormal satiety. So again, feeling hungry shortly after eating or in between meals. Emotional hunger in about 12%. This is hedonic eating, otherwise known as having cravings or eating because of anxiety or depression. And then the slow burn seen in about 12%, meaning they have an abnormal energy expenditure or slow metabolic rate. 27% of participants had more than 2 obesity phenotypes. And what happens when their treatment was based on their phenotype? So when the medications for obesity were applied based on the person's phenotype. Well, 312 of the participants were assigned to get phenotype guided or non-phenotype guided treatment. The people who had hungry brain, again, that was abnormal satiation, they were given either phentermine and Topamax, or Belviq. Belviq isn't on the market anymore, but phentermine and Topamax are, so I'll be talking about that medication. People with emotional hunger, eating for emotional reasons, or hedonic eating, were given the drug Contrave. This is a combination of bupropion and naltrexone, and I'll be covering that medication later also. People with hungry gut, so abnormal satiety, were given liraglutide. At that time, that was the only GLP-1 agonist that was FDA approved for overweight and obesity. And then people who had slow burn, so a slow metabolic rate or energy expenditure, were given phentermine and resistance training to increase their muscle mass. And what they found was at a year, participants who received their medication based on their obesity phenotype lost more weight, 1.75 times the weight as somebody who was not given that. And about 80% lost 10% of their body weight, whereas only a third lost 10% of their body weight if their treatment was not guided by their obesity phenotype. So it was very helpful to do that. And this is an example of the results. So the obesity phenotype testing is based on extensive questionnaires, also looking at 30 different genes that are related to food intake, digestion, absorption, and utilization and elimination, and then additional factors. And so the obesity phenotype is determined, and then the participant or the physician gets recommendations based on the phenotype in terms of what diet, eating strategy, and medications may be the most beneficial. And this is something, by the way, that you can order yourself. You don't need a doctor to do it. You can click on the link at the bottom of the page and it will take you to their website to be able to order. So this is something I've used in my practice. I don't use it on all participants because oftentimes doing a very thorough history will give me the information I need, but it is very interesting to do this. I've done it on myself. So let's switch gears again and talk about hormones and the role that hormone balance plays in weight. And the three main hormones I'll be talking about are insulin, cortisol, and the sex steroids. So that's estrogen and testosterone for the most part. Let's start with insulin because it's very important. So what you'll notice is a fat cell. This is a white fat cell. And you're going to notice that if you look on the left side of the screen, there's something called LPL. This is lipoprotein lipase. And insulin increases lipoprotein lipase in terms of its production and its activity. And lipoprotein lipase is what brings the triglyceride that's in the bloodstream into the fat cell. So that triglyceride or fat that's in the bloodstream goes into the fat cell because of lipoprotein lipase. And there's more lipoprotein lipase with more insulin. And then that fat or that triglyceride is broken down into fatty acids. And insulin helps the fatty acids turn back into triglyceride for storage. So insulin equals bring more fat into the cell and make more fat within the cell. If you're metabolically healthy, there's very little glucose taken up by the fat cells. So if you look in the bottom left-hand side of the screen, you'll see that glucose can be brought into the fat cell through GLUT4 with the help of insulin if there's a lot of insulin around. But if you're very insulin sensitive, most of the glucose in your bloodstream is stored as glycogen in the muscle. Very important. One of the most important reasons that we want you to be insulin sensitive if you're going to lose weight and maintain insulin sensitivity if you're going to maintain that weight. And this is part of the reason we talk so much about insulin resistance, exercise, etc. Because if you are insulin resistant, again, GLUT4 is activated and you will bring more glucose into the cell. And then you'll notice that that glucose is turned into fatty acids. So extra glucose is actually turned into fat. So a couple of different ways that you can store more fat in that fat cell. And then as you have more and more insulin, the fat doesn't leave. So if you notice that TAG or triglyceride, that can leave the cell through the activity of hormone-sensitive lipase. And hormone-sensitive lipase is inhibited by insulin. So that means the fat is brought into the cell, stored in the cell, and doesn't leave the cell. You need a very low insulin to increase lipolysis or the breakdown of fat tissue. Now, there's no insulin monitoring devices on the market right now for patients to use, but you can learn a lot from monitoring your glucose levels. And this is a picture of the Stelo, which is the over-the-counter CGM that's now available. So Dexcom markets this CGM to patients directly, so you don't need a prescription. It's significantly less expensive for patients. You can click on that link and order it yourself. The Stelo lasts for 2 weeks, so 14 days, and gives you real-time feedback about your blood sugar levels. I have no affiliation with Dexcom or Stelo. I've been using Dexcoms with patients for many years, and now we use the Stelo in my weight loss program to teach patients about their blood sugar and therefore their insulin levels. I've worn them for years. They're a very useful tool. You can also order a Dario glucometer. So the Dario works in your phone. It is surprisingly accurate. When I first got this several years ago, I checked it with my AccuCheck in the office, and I couldn't believe that there was a blood sugar monitor that works through the phone that was accurate. But it is very accurate, and it's very inexpensive. I think they charge like $30 for it. You have to pay for the strips a little bit more, but that you can use to start checking your blood sugar. So using some sort of device to monitor your glucose levels is really useful because you want to identify spikes as well as high glucose. So if your blood sugar is much above 140 1 to 2 hours after eating, that would be too high. That's just too high of a glucose level. Now, on occasion, it's fine, but if it's regularly above 140, that's a spike that you don't want. It really should return back to baseline, less than 100 within a couple of hours, and that'll depend on how much fiber or fat is with the meal, whether you're on a GLP-1 and there's slowed gastric emptying. But for the most part, you don't want your blood sugar much above 140 after eating, and then you want it to go back down to baseline relatively quickly after eating. And there is research that if you wear a CGM that detects glucose spikes, you will have more hunger, poorer mental health, lower sleep quality, and a greater risk of dying from cardiovascular disease if your CGM detects glucose spikes. So really important for you to wear it to detect that, and then to learn how to eat better so that you don't have glucose spikes, and how to exercise appropriately and use the appropriate hormones and then exogenous substances to help you. Okay, what about thyroid hormone? Well, thyroid is a very important hormone for your metabolism. Low thyroid hormone or hypothyroidism can cause weight gain. It doesn't usually cause massive weight gain, but it can cause weight gain because it does slow metabolism. Treating subclinical hypothyroidism, so if your TSH is high, but your free T4 and free T3 are normal, it rarely leads to significant weight loss. So sometimes patients will come in and they're certain that their weight gain is just due to their thyroid, and it rarely is that simple. But it is important to make sure that you have a normal free T3 and free T4 if you are in a weight loss program, because you will do better during that program. It does increase your resting metabolic rate. And specifically about T3, this is the active hormone. This is the hormone that T4, which is what's made in the thyroid, converts into. And greater than a 5% weight loss can decrease the conversion of T4 to T3. So important to monitor your free T3 levels if you are losing a significant amount of weight to make sure that they're optimal. And if you're on a ketogenic diet, that can lower T3 production. So let's talk about cortisol and weight. This is from a card my mom sent me many years ago. I've been a lot more stressed. I've been a lot more relaxed since I discovered that stressed is just dessert spelled backwards. We all know that we tend to eat maybe a little less healthfully when we're stressed. And why is that? One of the reasons is because cortisol increases appetite and the intake of high calorie, read comfort food. Chronically elevated cortisol also increases visceral fat, and that's because the fat cells in the abdomen, abdominal fat cells, have more receptors for cortisol. And also there is a enzyme made within the fat cells called 11-beta hydroxysteroid dehydrogenase type 1 that makes more cortisol from inactive cortisone. So you keep recycling it. And we just talked about insulin and insulin resistance. Well, guess what? Chronically elevated cortisol increases insulin resistance through numerous pathways. Now, this is one of those slides that when you're sitting in a presentation, you groan when you see, but it was so fun to find this paper that I couldn't help but put the slide in there. And if you click on the link, it'll take you to the paper. But this paper essentially is talking about how short-term stress, but stress that happens over days or weeks and then months to years, influences insulin and type 2 diabetes risk. Cortisol also inhibits fat loss from cells when insulin is present. So initially, when you're stressed, you can lose weight. Fat can leave the cell through adrenaline and cortisol. But if insulin is present, it increases fat storage and prevents it from leaving the cell. This is why it is so hard to lose weight if your stress level is high. High cortisol also inhibits thyroid hormone production, release, and peripheral conversion. So cortisol and thyroid have a relationship in that if you're stressed long term, your body is going to try to slow down to conserve energy. And since the main hormone responsible for that is thyroid, it prevents thyroid from being made, released, and converted into active thyroid hormone. What about growth hormone? Well, growth hormone deficiency lowers lean body mass and increases fat mass. This is shown in men and women. And if you're deficient in growth hormone, if you have low growth hormone, supplementation increases muscle and decreases fat. This has been shown by meta-analysis of 54 randomized trials. Perhaps peptides that stimulate the production and release of growth hormone will have the same result. At least that's what I've seen personally and clinically. And anyone who eats and has a gender knows there are gender differences in body composition and eating behavior. In the US, obesity is a little bit more common, 41% in women, whereas 39% in men. And hormone receptors on fat cells are different based on their location. So subcutaneous fat under the skin has more estrogen and progesterone receptors, which makes sense. We're women, we're curvy, and we're meant to store fat subcutaneously. Visceral fat, or fat surrounding the organs, the bad inflammatory stuff, has more androgen receptors. And sex hormones may also influence eating behavior. Women often prefer higher carbohydrate food and sweets, whereas men higher fat. So testosterone, extremely important for men. Supplementation with testosterone, if testosterone is low, has been shown to increase lean body mass and improve insulin sensitivity. And clinical trials up to 8 years have shown that it reduces body fat and sustains that weight loss. So very important to have optimal testosterone levels if you're a man and you want to lose weight. What about menopause? What happens at menopause? Well, women gain fat and lose muscle during the perimenopausal transition. They also redistribute fat. So they tend to store fat in the belly. This is called like the menopot. And this is independent of their total fat mass. So unfortunately, especially with estrogen deficiency, you go from an hourglass to a menopot. Energy expenditure also decreases by about 10%, and physical activity energy expenditure by about 30% at menopause. So tend to burn fewer calories and then redistribute fat to the belly. And hormone replacement therapy has been shown to slow the gain of fat and loss of lean body mass. And this is mostly through studies looking at conjugated equine estrogen, so that's Premarin and Provera, which is a synthetic progestin, through the Women's Hope study, and also through the WHI, again with synthetic estrogen and synthetic progestins. What about bioidentical estradiol, especially with semaglutide? So this is a retrospective study that was published in menopause of 100 women. 16 of them were on hormone therapy, so bioidentical estradiol, 90 were not. They had better results on semaglutide. They had more weight loss at 3, 6, 9, and 12 months. More women on the estradiol lost 5 and 10% of their body weight. Half of the women, by the way, were on the estradiol patch, and half were on oral estradiol. What about testosterone in women? Testosterone is not just for men. Low testosterone correlates with the loss of muscle mass. So estrogen is important for muscle mass, and so is testosterone. And then testosterone supplementation, especially at higher dosages, increases lean body mass and strength. So let's shift gears from hormones to supplements. First, important to recognize that we as human beings are completely outnumbered by gut bacteria. The GI tract contains at least 100 trillion bacteria, mostly in the large intestine. In fact, if we look at the number of genes made up by the intestinal microbiota, it's 150 to 500 times more of their genes than our genes. So we are more bugs than we are human. And this is a very interesting picture that was published by Pendulum Therapeutics of the gut metabolism axis. And what you're looking at is a relationship between the good bacteria in the gut. We'll be talking about Akkermansia muciniphila and some other bacteria that create short-chain fatty acids like butyrate. And butyrate is food for the cells of the colon. So it helps the colon in terms of making mucus to prevent leaky gut. And it helps because it increases GLP-1, which can then help with food cravings and with satiety and insulin sensitivity, etc. So the gut plays a role in weight and in a really large way. And mostly this is through different bacteria and then what the bacteria eat. So we need to talk about fiber. Fiber feeds the good gut bacteria. It is a prebiotic. The gut bacteria ferment that fiber, creating short-chain fatty acids, most commonly acetate, propionate, and butyrate. And this stimulates GLP-1 and decreases glucose. Very important. There's viscous soluble fiber that you can supplement with. Of course, you want to get most of it from your diet, but you can supplement with pectin, beta-glucan, psyllium, or glucomannan. This has been shown to decrease appetite and increase fullness. I've used Ultrafiber Synergy in my office for many years. This is glucomannan because there's good research behind it. I've also used it for myself, and it's very inexpensive. The dosage is 1.6 to 3.2 grams or 3 to 6 capsules with 8 ounces of water about a half hour before eating your 2 biggest meals. Super important if you're going to take this, if you mix the powder, that you drink it right away. I've made the mistake of mixing it and letting it sit, and you can practically turn the cup upside down. So it is a really good, useful tool to help increase your fiber intake. And then the one we use now and with the weight loss program is Mega Pre. This is a fiber blend that boosts the beneficial gut bacteria. Again, 3 to 6 capsules or a half to 1 scoop, 1 to 2 times a day. But really important that start low and go slow. If you get gas or bloating when you take fiber, you might have small intestinal bacterial overgrowth or other GI issues. And at that point, you're going to want to identify that, not just take more fiber, so that you can take care of that problem before supplementing with fiber. And speaking of Akkermansia muciniphila, this is a bacteria that normally should be inhabiting the gut. Higher amounts of that little critter are associated with a lower risk for type 2 diabetes, cardiometabolic disease, and inflammation. And then lower levels of Akkermansia muciniphila and other bacteria that convert the fiber to short-chain fatty acids like butyrate are associated with an increased likelihood to be obese, have non-alcoholic fatty liver disease, prediabetes, or type 2 diabetes. Metformin may increase Akkermansia muciniphila numbers and other butyrate-producing microbes. And fecal transplants from healthy subjects has been shown to improve insulin sensitivity in type 2 diabetics. So just to clarify, this isn't poop that the type 2 diabetic swallowed. It was actually put into their small intestine. But it does improve their insulin sensitivity just from transplanting that healthy fecal bacteria. Now, keep in mind that Akkermansia muciniphila is an anaerobic bacteria, so it needs to be made in an oxygen-free environment. Other butyrate producers are also anaerobic in the large intestine, so oxygen will kill them. So let's talk about which supplements, probiotics and prebiotics, might be beneficial. I really like this company, Pendulum. I've used them for several years now in patients. And Pendulum figured out a way to make Akkermansia muciniphila and keep it alive. So, because again, it's an anaerobic bacteria. The Akkermansia 500 Pro has 500 million bacteria per capsule, also has a little bit of inulin in there, which is a prebiotic that feeds the bacteria. So it's a type of fiber. And then their product called GLP-1 probiotic also has another bacteria in there, Clostridium butyricum and Bifidobacteria infantis, along with that chicory to help boost GLP-1 production and then help with weight loss that way. The product called Glucose Control, also another probiotic with a little bit of prebiotic in it, has a couple of other different bacteria in it and has been shown to help more with blood sugar, lowering A1C by about 0.6% and postprandial glucose spikes by about 32%. So if you notice with your CGM that you're spiking glucose, or if you are diabetic or have a high A1C, this is a good choice for you to help with your blood sugar control. And then a product that I think is a good one for people once they've reached their ideal weight is the Metabolic Daily Pro. Has 1 billion organisms per capsule. It's a good daily metabolic probiotic to help maintain weight loss. And then there's a product that's marketed by Metagenics. It's a postbiotic. So a prebiotic is essentially something that feeds the probiotics, types of fiber. The probiotics are the bacteria themselves. And then the postbiotic is going to be either bacteria that's been killed, heat treated, pasteurized, exposed to oxygen. But in any case, that bacteria is no longer alive, but the products that it produced are beneficial. And so the Ultraflora Healthy Weight with Akkermansia that Metagenics markets also has green tea in it, EGCG from green tea, and then chromium to help with blood sugar regulation and weight. And there was a clinical trial on this product in 40 participants who were overweight or obese and had insulin resistance, showing that they were able to lose about 1 pound of weight. So none of these probiotics are going to be miracles, of course, but in addition to a comprehensive program, are going to be beneficial. And then one of my favorite spore-based probiotics, Megaspore Biotic, which contains 5 different spores. So these are bacteria that are dormant until they reach the large intestine. And this type of spore-based probiotic has been shown to help with leaky gut and the gut barrier, and to lower ghrelin, to lower hunger, and potentially improve immune function, lower inflammation. And this is the product that we use for the weight loss for longevity program. Because when I started using GLP-1 agonists years ago when they came out, I made the mistake of not reconditioning the gut initially, and people had side effects. So now the GI side effects happen very rarely in my patients because I focus on gut restoration initially. So we use this 3-month protocol, which is the Megaspore, the spore-based probiotic, the Megapre, which is the prebiotic or the fibers that help feed the gut bacteria, and then Megamucosa, which helps rebuild the lining, helping with leaky gut. And so this is part of the program that we use. It's a 3-month protocol, and so all patients start on this protocol. So what about berberine? You may be hearing about berberine as a, quote, natural GLP-1 agonist. This is a substance that's found in Oregon grapefruit. So we have lots of Oregon grapefruit here in Oregon. Unfortunately, you have to dig up the root to get the berberine because you have to scrape the root. But this may help with weight loss and lower CRP. It has been shown to reduce fasting blood sugar, A1C, insulin, triglycerides, blood pressure, and to increase HDL cholesterol, so it can help with cardiovascular health. The effective dose is at least 1,000 milligrams a day, so 500 twice a day. You can use a lower dose if it's a more absorbable form and have good activity that way. Another supplement called CaloCurb, we've used this in my clinic, and I'm really intrigued with how the researchers came up with this formula. This is an extract of hops that comes from New Zealand, and it was studied in healthy weight participants. As far as I know, it hasn't been shown to help with appetite or weight loss in overweight or obese participants, but I think those clinical trials are ongoing. But it does decrease calorie intake at meals in the healthy weight participants through the idea that it's part of the bitter break. So it's a very bitter substance which can decrease calorie intake and food cravings in people who are fasting. And so my patients who say, I don't want to take medication, or I just want something to help me once I've reached my ideal weight, this is something that there is some clinical trials on. I don't see side effects with it, except for maybe a little bit of GI upset if a participant takes too much. So this is something that you can also use and is helpful. And now let's talk about medications. So the natural therapies are useful. Medications are also very useful. Because remember that obesity is a chronic disease that must be managed for life. So if you're not reaching your ideal weight goals, there is no harm in using medication, or I should say there's no stigma, at least not from my standpoint. I believe just like I need glasses and I need the right prescription, that a patient might need a medication, and they might need the right prescription to get to their healthy weight. And again, that's because I do longevity medicine, and I believe in extending lifespan and health span, and a big part of that is going to be to achieve an ideal weight. Most medications that work for obesity target the brain and appetite, and I want to go through them. Now, if this is overwhelming, you can just skip forward and we can talk about the GLP-1 agonists, but I think it's important to cover other medications that I often use because they're very helpful, and they might be a better choice in addition to GLP-1s or instead of GLP-1s for many patients. The first one is good old phentermine. This came on the market in 1959, and there's a record player from 1959. So it's an oldie but a goodie. It suppresses appetite and it increases metabolism a little bit. So this is a good choice for people maybe who are starting on a GLP-1 agonist and maybe have a lot of weight to lose. And so it's likely that they're going to need a higher dose of that medication, and it may take a while for them to titrate up to that dosage. So sometimes phentermine at the beginning can be very useful for that. Keep in mind it is similar to amphetamines. So it does increase norepinephrine and dopamine release. It peaks in about 3 to 5 hours, and the half-life is 20 hours. So it's, half of it's in your system 20 hours later, which is why it can lead to insomnia. Really a drug that's meant to be used short-term for up to 3 months. So tachyphylaxis or downregulation of receptors and activity of this drug occurs usually around 12 weeks. So it's not really meant to be a long-term medication. And please don't use this if you have an arrhythmia or atrial fibrillation or cardiomyopathy. Uncontrolled high blood pressure, if your blood pressure is controlled, you're fine using this medication, or any other contraindication like a seizure disorder, Parkinson's, pulmonary hypertension, anything like that. And then there's a drug called phentermine and Topamax put together that you can use. Adding Topamax enhances the activity of this drug because it binds to GABA receptors and antagonizes glutamate. So this helps more with binge eating disorder. Topamax is also used for alcohol use disorder. It's also used for seizure disorder. It gets better weight loss for some people than phentermine alone. It is really expensive, but phentermine and Topamax are both generic and very inexpensive. So if I use this, I'll use the two medications separately and have people combine them because it's a lot cheaper that way. Phentermine side effects, heart racing, heart palpitations, increase in blood pressure, so monitoring blood pressure is important. Sometimes insomnia, restlessness, it can feel like speed, especially when you initially go on it, dry mouth. With Topamax, long-term, I don't recommend Topamax long-term because it can lead to memory impairment or dizziness. And then, of course, GI side effects are always possible with any medication. The next medication, naltrexone and bupropion, this is known as Contrave. You may recognize bupropion, which is Wellbutrin. It's a common antidepressant, and it's a dopamine and norepinephrine reuptake inhibitor. Naltrexone is an opiate receptor antagonist at high doses. So it blocks opiates from binding to the receptors, and it's used mainly for alcohol dependency, but it can also work for people who especially have an alcohol use disorder or food addiction or food cravings. It has been shown to help more with weight loss than diet and exercise alone. If you are a heavy alcohol user or alcohol dependent, keep in mind that abrupt withdrawal of alcohol can lead to seizures. So please get help with that before going on this medication. And then, of course, if you have any contraindications to this, Contrave is very expensive. Some insurance companies do cover Contrave. If they don't, then I use bupropion and naltrexone generically. We have to cut pills to emulate the drug, but it's very effective and very cheap that way. So Contrave, another good medication to use for weight loss. Side effects, potential side effects of naltrexone and bupropion: headaches, dizziness, insomnia, and tremor. And that usually is when you discontinue the drug, that can go away. And then GI side effects, and watch your blood pressure. So now let's talk about the GLP-1 agonists, the blockbuster drugs. These are drugs that bind to GLP-1 or glucagon-like peptide 1, which is made in the intestine, the pancreas, and the brain. Specifically, the L cells in the small intestine and the colon secrete GLP-1 when nutrients are present. And this, as you already know from our earlier slides, stimulates insulin and inhibits glucagon release. And it also slows stomach emptying and gut motility, so you feel fuller longer. This is how it decreases appetite, both in the gut itself and in the brain. Originally, these drugs were approved for type 2 diabetes, and then liraglutide was the first GLP-1 agonist that was approved for weight loss. Unfortunately, it needs to be injected daily, and then semaglutide, and now tirzepatide. Kind of an interesting story about how these drugs were discovered. An endocrinologist at the VA named John Eng in New York in 1990 noticed that the saliva from Gila monsters, which are lizards that are found in New Mexico and Arizona, is what enabled them to only eat every few months. And he named this peptide exendin 4, which was changed to exenatide, otherwise known as Byetta. So Byetta was FDA approved for diabetes. It's GLP-1 has a very short half-life. So keep in mind, when you're increasing endogenous or made in the body GLP-1, this is only active for a couple of minutes. So, protein, the GLP-1 that's released from short-chain fatty acids, this is active only for a couple of minutes, whereas the half-life of exendin was 2 to 4 hours. So this was a really important discovery, like how to keep this substance around longer. And then, of course, the GLP-1 agonists now, not only do they have much longer half-lives, but they also are much greater in terms of their activity than endogenous or made in the body GLP-1. Just going through a few of the clinical trials that were used to approve these drugs. The step 1 and step 3 trials combined, they had about 2,600 adults. Most of them were women, followed for over a year, 68 weeks. All the participants did follow a low-calorie diet, and they were also encouraged to be active, to have at least 100 to 150 minutes of exercise a week. Their food intake was monitored. They were taught to challenge negative thoughts and obtain social supports. And then they used an activity tracker and recorded their food in a diet diary. I think that's an important thing to cover, because the clinical trials didn't just give participants a drug and then the placebo group a placebo drug. They were actually engaging in a lifestyle and course while they were going through this. And that's why there was weight loss seen in the placebo group, because we know that mindfulness training and lifestyle helps with weight loss. So the average weight loss was 15% in the group on semaglutide, and 2.5 to 5.7% in the placebo group. 86% of the participants lost 5% of their body weight versus 31 to 48% of those who were on the placebo, or the intervention was the lifestyle. 70 to 75% lost greater than 10%, and greater than 50% weight loss was seen in more than 15%. This was a really big deal when these trials were published. And then the people on semaglutide had better blood sugar, A1C, blood pressure, CRP, and lipids, which we would expect with weight loss. What happened when the drug was stopped? This was a trial looking at 2 trials that looked at 4.4 years after stopping the semaglutide, that the participants did regain their weight. They had a net loss at 4 years of about 5.6% versus 0.1% in the placebo. So about 2/3 of their prior weight loss was regained. Why? Because obesity is a chronic disease that needs to be managed for life. If the semaglutide was continued for another 48 weeks, so 68 weeks total, they lost 17.4% on average. So they lost additional weight if they continued the drug. What about side effects of semaglutide? Most of them are GI related. Possibly less likely to happen if you recondition the gut, which of course is part of our weight loss for longevity program. But nausea, constipation, those are very common. GERD, mainly because if you're overeating too much and your stomach is not emptying, you're going to have some reflux of stomach contents and heartburn. And so you want to eat smaller amounts for that reason. Also not eating and then lying down, because that's going to be more likely to cause GERD. Gallstones, that's possible with all weight loss. Fatigue, does it cause fatigue? I'm not sure. A lot of people will complain of fatigue who are not on a weight loss program or on any weight loss program, because of course when you drop calories, you can be tired from that. Sometimes a little bit of an increase in heart rate. Low blood sugar if you combine it with insulin. So if you are on insulin, of course, make sure that you're doing this with a physician who's skilled in using these medications. And then injection site reactions. There is no increased risk of thyroid disorders or thyroid cancer, rarely an increased risk of pancreatitis, which again can happen with all weight loss, and retinopathy in diabetics. I'm not sure that data is clear yet, but that's always a rare potential side effect to watch for. And this is a meta-analysis of 30 randomized clinical trials with 30,000 participants at about a year. The semaglutide and liraglutide studies were at 68 weeks, but you'll notice that semaglutide significantly more effective than the other medications that were used. And then the newest medication to be FDA approved, tirzepatide. So whereas semaglutide is named Wegovy if it's given for weight loss, and Ozempic if it's given for diabetes, tirzepatide is known as Mounjaro if it's given for diabetes, and Zepbound for weight loss. The exact same molecule, just different name based on the indication. And this binds to GLP-1 as well as GIP. And you'll notice that for the most part, GLP inhibits appetite where GIP doesn't. That's one of the main differences. And the thought is that the GIP enhances the GLP-1 activity. So the trials for tirzepatide for weight, these were called the SURMOUNT trials. The first one was SURMOUNT 1, that was 2,500 participants on dosages from 5 to 15 milligrams or placebo. And these were people who did not have type 2 diabetes. And the weight loss was 15% in the low dose and 21% in the high dose versus 3% in the placebo group. 85% of participants on the low dose lost at least 5% of their body weight, whereas 91% of participants on the high dose did. SURMOUNT 2 included 1,500 people in 7 different countries. They were on the little bit of a higher dose, 10 or 15 milligrams, a little bit longer for 72 weeks, and their weight loss was really similar. In SURMOUNT 3, lifestyle intervention was used, so low-calorie diet and exercise counseling. 7% average weight loss was seen initially if they were just doing lifestyle. Again, what we tend to see, 5 to 7% with lifestyle. And then they were randomized to either receive tirzepatide or a placebo for an additional 60 weeks. And the tirzepatide group lost a total of 24% versus 3.6% in the lifestyle and placebo group. And those who lost at least 5% of their body weight, 94.4% in the treatment arm. Pretty astounding. And then SURMOUNT 4 was 36 weeks at 10 or 15 milligrams, 21% average weight loss. And then they were randomized to continue for a total of 52 weeks, for another 52 weeks, so another year. And what did they find? That the people with tirzepatide lost an average of 26%, whereas those on the placebo actually gained their weight back, about 15%. Side effects are similar, although potentially less common. That's something I've seen clinically. It's something reported in the literature. Maybe a little less nausea, vomiting, constipation, and diarrhea. Again, you'll notice heartburn, gallstones, and low blood sugar, especially if you combine it with insulin. What about looking at the two of them? So this was a meta-analysis that was just published last year, looking at 28 trials that included tirzepatide or semaglutide and about 23,000 participants. The highest dose of tirzepatide, average weight loss was 21 pounds, whereas the highest dose of semaglutide that would have been used for weight, not diabetes, was about 11 pounds. So the highest dose of tirzepatide was better than semaglutide, and the participants had better blood sugar regulation. Now, the amount of weight loss was significant. Sometimes I talk to patients, though, about expectations. So tirzepatide is more expensive than semaglutide. Oftentimes, unless someone has a contraindication, I'll recommend starting at semaglutide if semaglutide is ineffective or if they have side effects, switching to tirzepatide, because if you've used tirzepatide and it's not effective, usually you don't go backwards. Another thing to keep in mind is that there have been reports of people switching from semaglutide to tirzepatide having anaphylaxis. This is something I heard from physicians who took my course that I presented at. And so, because there is some talk about that, really important if you do switch from semaglutide to tirzepatide to have a washout. So maybe don't use any GLP-1 agonists for at least 2 weeks so that the semaglutide is out of the system. So what about combining therapy? Well, this is something I like. The idea of is that it seems that we'll get a synergistic effect if we can combine therapies. Not a lot of research on this, but certainly makes sense. And that's why I developed the Weight Loss for Longevity program so that we could use multiple different interventions with the hope of achieving the best results and maintaining those results. But this was an interesting study that was reported from 400 patients at an obesity clinic in Canada. Most of them were women, and it was a retrospective study. So they looked back and noticed that the participants who were on Contrave, the bupropion naltrexone, that was added to their liraglutide or semaglutide, lost an additional 4 to 5% body weight at a year. So adding Contrave or bupropion naltrexone to the GLP-1 agonist, especially if someone's not at goal, might be more beneficial. And potentially coming soon, there is now a triple agonist called retatrutide. So this has more GIP, a milder GLP, and glucagon agonism. The phase 2 trial was published last year that showed 23 to 24% weight loss, so even a tiny bit better than tirzepatide at 48 weeks, but 100% of the participants lost at least 5% of their body weight. We have never had a clinical trial, as far as I know of, that has shown that. Also lowered LDL cholesterol by 20%, and it improved metabolic dysfunction associated steato fatty liver disease. And basically all weight loss will show an improvement in fatty liver. I don't know if it's safe. I do know there are compounding pharmacies that are already making it, but it has not been FDA approved. I don't use it until it is FDA approved. I don't know if it's safe, but it does look like it's effective. So to summarize, I think it's helpful to understand the causes of obesity, especially if you have overweight or obesity, whether or not they're biological, genetic, environmental, or behavioral. Remember that when you absorb more calories than you burn, that's why you gain fat, so calories matter. What ideas can we agree upon? All diets can work short term. Weight loss is mostly about calories. Fiber and protein are good, and ultra processed food is bad. Counseling and lifestyle intervention matters. Unfortunately, regain of lost weight is the norm because of the set point, and you need a strategy, not a diet. Remember the set point theory that your body will adjust to and defend an increase in body weight. This is not a character flaw. It's not a choice. It's physiology. And that's because of the relationship between the hypothalamus in the brain, the fat cells themselves, and the GI tract. And the benefits of weight loss are that you'll live longer, you'll have a longer health span and reduced health risks from diabetes, blood pressure problems, cardiovascular disease, fatty liver, sleep apnea, and many forms of cancer. An improved sense of self and well-being, and you'll be more physically active and more able to function. Remember the 4 tools or steps: accountability, mindful eating, hormone balance, and supplements and medications. And the reason that I believe that is because obesity is a chronic disease that needs to be managed for life. It's adiposity-based chronic disease. So I'd like to talk just a little bit about my Weight Loss for Longevity program. And I believe we're in the midst of a longevity revolution. It's a very exciting time to be practicing longevity medicine. I've been in this field for 24 years, and it's never been more exciting. But when participants come in and they're taking exogenous molecules and asking me questions about rapamycin, or should they take metformin, or should they take this supplement or that supplement, I first start with healthy body composition. I think it's the low-hanging fruit that needs to be focused on. If you want to lengthen your lifespan and your health span, you must achieve an ideal body composition. And that's more important than any substance that you take in. And that's why I developed this program. It's a 12-week program. It includes body composition testing. So we do a DEXA scan and a bioimpedance analysis with a SEICA at the first visit. We do the SEICA at the second, 4th, and 8th visits because we want to make sure that you're losing fat and not muscle. We repeat the DEXA at 3 months. Everybody will work with a certified functional medicine coach, and she is fantastic. I'm so excited about bringing her on board during the first week, and then 3 additional sessions throughout the 12 weeks. Sometimes participants need more coaching and help, and that's always available. And she works with participants on their nutrition, exercise, sleep, stress management, anything they need that's personalized. Everybody gets a Stelo glucose monitor for the first month, and that's because I want you to learn about your blood sugar and insulin, and we'll discuss the results. If you choose, we're able to see the results in real time, just like you are, and so we're able to dialogue about those results. Everybody gets a gut restoration kit. Again, gut restoration, very important, whether or not you're going to go on medication, important to help with weight loss and important to maintain weight loss. And then the program includes a GLP-1 agonist, a semaglutide for the 12 weeks. If a participant prefers tirzepatide, that costs us more money, and so we do charge more for that. And then if other medications are needed, the costs for those are dependent on what the pharmacy charges. And if a participant doesn't want to use a GLP-1 agonist, they can use Calo-Curb. So thank you so much for attending this program. And I just want to give a very well-deserved shout out to my husband, Daniel, because he's been my life partner, and he is kind of like the background singer who doesn't get enough respect and kudos. And without his help and support, I couldn't be doing this right now. So to you. And I hope that was useful.